I obtained my PhD at the School of Pharmacy, University of London, where I conducted research to look at the reasons that cancer patients can't manage their treatment and are non-adherent. And a lot of my patients came from Hammersmith Hospital of Imperial College London, and mainly chronic leukemia patients who were taking oral drug called imatinib. And after I finished my PhD, I continued my research at Imperial College as a postdoc, and after that I joined Atlantis Healthcare as a clinical strategist. And my job here is mainly to develop patient support programs and adherence interventions which are helping patients to manage their illness and their treatment better. So CML is a rare form of blood cancer which is affecting the white blood cell. And this is one of the cancers where they identified an exact cause, which meant that they could develop highly targeted drugs. And the first-line treatment, imatinib, was licensed in the early 2000s. And with the launch of imatinib, we completely changed the state of this illness from having previously been a terminal illness where patients often died within 5 years, unless they could have a bone marrow transplant, which is a very risky process, and to become a chronic disease where patients have to manage themselves at home with an oral treatment like imatinib. And with that, we have the problems of many chronic diseases, or essentially all chronic diseases, where patients have problems adhering or choose not to adhere to their drug. So research have shown that about a third of CML patients find it difficult to adhere to their treatment and have suboptimal adherence level. And this have been found to be one of the most important factors which affect clinical outcome, and also it tends to increase healthcare costs. For example, one of these trials was the Hammersmith trial that I was involved with, in which we used medication event monitoring systems, or MEMS, which is recording each time the patient is opening with a little microchip which is inside the lid. And what you do is to replace the normal lid of the medication bottle with the MEMS lid. And then the recordings is downloaded, and you get a really nice display over time exactly when the patient have opened the MEMS bottle. And we make the assumption that at these time points the patient is actually taking the dose. And we found that the adherence levels as measured with the MEMS is the most important predictor of clinical response in these patients. And because of that, it's very important to understand why patients miss doses. And we also conducted interviews with the Hammersmith patients to find out exactly why they are missing their doses.
I've taken imatinib, or Gleevec, a 600 milligram dose for a few years now. And I recently took part in a study which measured how I took my treatment. I thought I did all right with my Gleevec. I mean, I knew I was missing days, but I didn't quite realise how much I was missing. So after the study, I asked how much I'd actually been missing, and it worked out that I'd missed maybe 20% of the doses over a 3-month period. So it wasn't working quite as well as it could do. So they said, well, we'll bring your dose down to 400 milligrams and make sure you take it every day. And the side effects haven't been quite so bad. So it's been much more manageable to do that. And I haven't missed any because I know I'm taking less and I wanted to work on less. And I've been trying to make sure that I take it every time.
This patient who was part of the Hammersmith trial was not alone in having problems with adherence, and all the different patients had different reasons for missing their treatment. And what we find surprising was that many patients didn't realize the impact of missing doses. And it seemed that this belief had been reinforced with healthcare professionals actually downplaying the impact of missing the odd dose. And we find that the most common reason for choosing to not take the treatment was to manage side effects, just like this patient in the interview. And we find that the most common reason for patients being unable to take the treatment was that they just simply forgot. If we can improve adherence to oral therapy in CML patients, then we're likely to improve clinical outcome, quality of life, and possibly reduce healthcare costs. Some key aspects in terms of supporting adherence in CML patients is to manage side effects appropriately that they experience, also making them aware of adherence aids that might be available to them, such as alarms or monitor dosing boxes. It's important to improve communication so that patients are aware of the consequences of non-adherence, but do that in a way to not alarm the patient. And I like to finish by saying that, of course, everyone has the right to not adhere if they don't want to, but patients have to be appropriately informed to make that decision. And if they choose to adhere to the treatment, then we need to provide the support so that they can do that in the best way.